So I'm Eliot, number 2. So I'm going to talk about process design a little bit, get a little more into the theoretical basis of what we do, and let's jump right in. So this was Cooper's landmark study in 1978, really kickstarted the whole safety thing in anesthesia, using critical incident analysis from industry and identifying the major contributors to adverse outcomes in anesthesia. And today we're going to talk about drug administration because that was number 2. But interestingly, if you look at the top 4, most of them are related to ventilators, circuits, and airway management. And in the last 40 years, we've made great progress and great strides in those. Things have changed a lot in that domain. But in terms of drug administration, which was way up there 40 years ago, we haven't made nearly as much progress. So we'll talk a little bit more about that today. This is a picture I just got online from a North American institution. And clearly somebody put a lot of effort into this. They've got labels, they've got styrofoam cutouts, things look very organized. And I hope by the end of this talk you can understand why this is woefully inadequate for what we're up against. And we, despite efforts to date, need to think really hard about how we can improve things, because there's still a lot of opportunity for problems, especially the vials we get every day look in different color, shapes, and sizes. And even though we've tried to improve things, there's still a lot of room to go. So stepping back for a second, as we heard earlier, our medication error rates, as long as we've studied them, the best data that we have changed little over the last few decades. Part of that's due to the complexity of the pharmaceutical industry that makes it a little more challenging, and part of it is just lack of focus. We haven't spent the same amount of time and effort that we have on some of our other safety issues. There are a lot of competing pressures. Medication security is becoming a big deal in Seattle right now. Sterility, infection prevention is becoming more in the forefront. There are efficiency and production pressures that always complicate what we do. And then, of course, electronic records. We have the wonderful experience of getting our second electronic record next year, so we get to go through that transition again. But really the take-home I want to get from this whole talk is simplicity leads to safety. This is a hard lesson that Boeing's starting to learn in the last year or so. Unfortunately, simplicity can be very complicated to achieve. And so that's really the lesson here. We're trying to make things simple, but that's not easy to do. So this is one example. So this is the OODA loop, the Observe, Orient, Decide, and Act. This was created in the 1950s by Colonel John Boyd from the Air Force during the Korean War. And you'll see a very simplified version of this in a lot of corporate boardrooms, the so-called OODA loop. My point here is that this is what we have to go through. It was designed for dogfighting, but it works in a lot of high-stress situations. Every time we approach a decision in the operating room, it's a very complicated process. And this whole left side here is the thinking part. This is why we go to training for years and years. This is the part that I heard a great talk about AI yesterday. I'm really not worried about it taking over this anytime soon. There's a lot that goes into making the decision to the right dose, the right drug at the right time. And that's not what I'm talking about today. I'm talking about once we decide what to do, we know what to do more often than not, but we need to ensure that it's automatic and it happens correctly 100% of the time. There's really no excuse for making the right decision and executing it incorrectly because of the way we handle medications. So as Karen alluded to, we did a failure mode and effects analysis. We borrowed another industry tool. We're big into Toyota and all that in Seattle. And just going into a little bit more detail, I know you can't read the specifics. The point being that we broke down, we've already gone through the 5 major steps. We identified 19 sub-steps. Every single time you pick up a medication, there's 19 things you go through to get from the decision to give that medication to actually giving and recording it. And 68 possible failure modes. It's every single time you pick up a medication. There's a lot of ways things can go terribly wrong. This is a horrendously complicated system. This is the standard. You pick up a vial, you draw it up, you go through the whole process we do every single day. It's very brittle. It relies on things like accuracy and vigilance, things the human brain is not known for. We're good at a lot of things, and those are not 2 of them, despite being our ASA motto. Single point failures all through this whole system. So it's a really, really brittle system. So the question is, how do we simplify this, and how do we make this much more robust? So this is another study from the 70s. I'm kind of a history buff. This was actually at UW. We're looking down in a bird's eye view. The anesthesiologist is the number 2 down here, and this was a study looking at our workspace design. I think there's 2 interesting, and here's the patient right here and the table. So we're standing at the head of the table, and this is our domain right here. It's interesting to note what hasn't changed since the 1970s, but I think it's really useful to think about what has. I divide our workspace into two sides. The right side, the ventilator, the monitor, the breathing circuit, lots of progress. The left side, the medications, the cart, the IVs, not much has changed since the 1970s. And so let's look at what do we have as far as countermeasures, right? The first day you walk into residency, the whole first chapter of the book you read is all about all the amazing countermeasures and safety things we've done to the machines. And there's a whole big long list, and I don't have to read them all for you, but it's all these little key words we learn on day one. And then you go to the left side, and you go to our cart and our big pile of vials and all the syringes scattered everywhere, and we don't have nearly the same countermeasures. We don't have any, if I give the wrong dose, no one's going to tell me. Maybe the patient will a little bit later with some grand physiologic disturbance. If I grab the wrong vial, there's not necessarily anything to identify that. Errors would get propagated through, we really have no way of detecting those until something bad happens. We don't have an analogous like our gas monitor that tells us at least some semblance of what's going on inside the patient. I have no idea what the plasma level of anything is. Essentially, our pharmacokinetic models are there's a bucket and a patient and we pour them in. And that's even in peds. We do everything weight-based, but that's essentially what we're operating with. So as we think about what kind of countermeasures we want to employ, I think it's useful to put them in a bit of a hierarchy. So when you think about how you're going to go about mistake proofing, really what we want to do is eliminate errors. We want to make them impossible. We want to make it so you can't do them. That's really the gold standard for how we're going to fix things. And it's useful to think about all the various things we try to do, all the countermeasures we try, and where they fit into this hierarchy. Detecting errors is important. Detecting defects, there's an error once it's made it through more of the process. All of our alarms are just detecting bad things after they've happened, and really not getting upstream to the point where we want to make some of these mistakes impossible. All these cognitive aids, I'm a big checklist proponent. We have 1 million of them in Seattle. I think they're useful in various contexts, but again, they're not necessarily going to stop you from doing anything bad. Hopefully they'll catch something later, but you really have to think about what types of interventions are we creating. So along those same lines, I talk about additive versus subtractive. There's an unfortunate pattern that we have, and we do this at my institution, where some terrible thing happens, we get a bunch of people together to make sure it never happens again, which is a laudable goal. You don't want to make the same mistake twice. But often what happens with these root cause analyses is that we end up complicating processes, we end up adding, layering countermeasures on top of things, and we end up with this airport security problem. Where you take off your shoes and your shampoo, it comes out, and everything else, and you just make it much more complicated. And you're not necessarily making it safer. People feel better at the end of the day, but you've made a very complicated system that now has other points of failure. The other area of complexity, we have these dual-use systems that we kind of pretend like are safety measures, but aren't really. So all these smart carts that are coming out from Omnicell and Pyxis and everybody else, great for medication security, great for reconciliation of what's in your cart, not necessarily a useful safety tool. Maybe related, might be helpful, but I don't want to pretend like it's going to solve our safety problems. And similarly with barcoding, I think has a lot of potential, but we have to be careful about what it was intended for and in what context is it useful. I mean, if you go to a supermarket, it's great for documentation, inventory, giving you a receipt. Not necessarily the most useful way to identify if an orange is an orange with a barcode, right? Maybe there's a different way to do that. If you think about our anesthesia machine, it doesn't require the same level of compliance and the same level of complexity. We've been able to remove options. We've been able to eliminate errors by taking things away, by making certain mistakes impossible, and by imparting certain constraints on what we do without impacting our workflow. I can still give all the gases I want, but it's really hard to put the wrong gas in the wrong vaporizer, right? So thinking about the difference between feedback versus constraints, and I think this is really important. I think constraints are very useful. Feedback is often what we find we're dealing with in terms of our countermeasures. So feedback is something that requires compliance and engagement. Like every medication label we have is essentially a form of feedback. No label is ever going to stop you from doing anything bad. Yes, we should read it, we should pay attention, we should be vigilant, but it's not going to prevent anything. It will hopefully help identify what's inside the syringe, et cetera, but you can still hook up any label to anything and it's not going to stop you. So a lot of what we do, color-coded syringes, again, I'm a big proponent. I think they're very useful. Barcode scanners, I think, have a role, but again, they all require a certain amount of participation on the part of the user. Whereas if you think about other things, if you get an infusion pump and you make it physically impossible to program with an extra decimal point, Now you've eliminated an error. You actually can't physically do that because the pump won't let you. If you think about standard concentrations coming from pharmacy, now you've eliminated some of the possibilities and sources of confusion. If you think about pre-filled syringes, now all the issues you have with vials go away because now everything's in a syringe, regardless of if it comes from a 503B or from your own pharmacy. These are much more robust countermeasures. So constraints, I like to think about, they eliminate steps, they eliminate options, they automate processes, and they often, if you can, the gold standard, physically prevent mistakes. And again, lots of examples in the machine. The pinned index system, the oxygen-nitrous coupling. There's all these things you can't do wrong anymore. And so why don't we apply these to the medication side? There's a lot of different types, various interfaces, coupling, you can segregate, you can standardize. There's a whole different way of doing it. You have to be careful. You don't want to impact the workflow in a way people can't make the decisions they want, people can't have the options they need, but there are certainly more often than not more options and more possibilities than are necessary. So some examples, let's get concrete and get out of the abstract. So this is just things from Seattle Children's. So we started out a number of years ago, we had a big box full of medications. There were lots of options. The vials showed up in various colors, shapes, and sizes every day. It was very confusing. They were alphabetical because that was easy for the pharmacy to restock them, but not necessarily helpful for the clinician. So you had high and low use meds together, high and low risk meds together. Similar things look different, different things look similar. We all know about this vial problem. So we sat down and said, okay, how can we organize this in a more rational way that's going to be more useful and safer for our providers? So we ended up segregating into two boxes. So now we have a single box, the primary tray, that we use solely 85% of the time. So 85% of our cases, we don't need to use more than 7 medications. Essentially, you do an LMA, anesthetic, and an adolescent, and you use everything in here, and you don't need anything else, and that's it. And now, all the other medications that you could get confused with and cause problems with aren't even in the box. So when you open it, first of all, it's hard to confuse 7 medications because it's not that many. That about 6 to 8 is probably the limit of what we can keep track of reasonably. And a lot of the bad things like our pressors and muscle relaxants aren't even in the box. So now you physically cannot confuse them because they just aren't there. Our secondary tray, the other medications we use commonly, but we found only about 15% of the time. You'll notice a couple highlights. The muscle relaxants have signifiers. They're in this bright red well, so it really stands out. But most importantly, you've separated things so that you don't have the opportunity for the same confusion. Pre-filled syringes, I'm a big fan. We're having major supply issues at our hospital, which upsets me. But again, you go back to our FMEA and this complicated process. You put a pre-filled syringe in this process, and now the whole preparation step is gone. Right? You've taken 19 ways you can do your job incorrectly, and they just evaporate like that because now you don't have vials in the system anymore. So it sounds simple, like, oh, pre-filled syringe, vial, whatever. It actually is an incredibly robust way of eliminating a huge amount of errors and simplifying the process. One day, 5 or 6 years ago, I went around and took pictures of our anesthesia workspaces, and it didn't really explain why. And it's a little horrifying. For me, I have this test I imagine in my mind. It's sort of the parent test. I work in pediatrics exclusively. And the question is, if a parent walked in and saw this, how would they feel now that they know their child is in life is in your hands? Not great. This does not pass the parent test. This is a mess. This is pretty standard in terms of what we used to have as far as workspace. And I hope it's fairly self-explanatory why in an emergency this is not an ideal situation. So we sat down, we spent about 5 years developing this medication template. Conceptually very simple. You go down to your local bike shop. You have a shadow board where all your tools go. Same idea. A little bit deceptively simple. This was like version 12. Our first 8 versions were way too complicated. A really nice example of how simple is hard, is a lot harder. We used to have a million different options and vials, but the concept is very simple. You've got your emergency medications we use in pediatrics sitting up on this platform in the back. You've got medications I really don't want to confuse like muscle relaxants and opioids, and the rest is wide open. The lesson for us was we learned that we don't need a spot for everything, we just need a spot for important things, and the simpler the better. I don't care where you put your propofol, you're not going to confuse it with anything. It's white, it doesn't look like anything except intralipid, we don't encounter that often. So this we found was a really nice way of cleaning up the workspace and also had some secondary effects. A couple quick shots of data. So this is real data from our operating room, real errors that we made at Seattle Children's. It's annualized data because they're not very frequent, fortunately. Whether that speaks to our collection methods or our clinical acumen, I'm not sure. But you'll notice that to the left that we had ticking along, these are syringe swaps, fairly constant rate. When you annualize the data, you take an instantaneous annual data, it highlights, if you have 2 in a row, real big. It shows a really bright signal, which is part of what's useful in this rare event. And then we did a suite of interventions, the medication template being the big one, and then you just see essentially it just disappeared. We basically haven't confused a syringe for years afterwards. It just went away. And what was interesting, we found in simulation when we first ran through some of this that organizing your workspace, that making things clear and standard had an interesting side effect we did not expect, which is that people made a lot fewer calculation errors. We did a simulation where we put people in an intense but simple task, basically give a weight-based dose of various medications. And it was interesting. And then we looked in our real operating room, and this is, again, real data on real patients, and we found our events of miscalculation error just kind of ticked along for a number of years. We cleaned up our space, we organized everything, and they essentially went away for years. We haven't had a miscalculation error in a number of years. So takeaways. So I think what we can do today, highlighting a lot of what I've already talked about, is just redesigning the way we approach medications, simplifying, standardizing, putting thoughtful constraints in. And then I think when it gets interesting, and what I really want everyone to think about is, well, what can we do tomorrow? So we take the analogy of the anesthesia machine. So Karen touched very nicely on our medication process, very different from the rest of the institution. I sit down in these administrative meetings about medication safety, and they're horrified by, you guys don't put in orders, and you don't, you pull these things out of a drawer, and like, dear God, like, what are you doing? And pharmacy's not involved. Yes, it's a liability, certainly, in many ways. To me, what I try to pitch is I think in some ways it's an asset. The standard way everybody else in the hospital does it is very complicated. Our process is very simple, and it's very contained. And I think there's an opportunity, and I don't have the answers yet. I call it the espresso machine, probably because I'm from Seattle, but this idea of we took all of our airway and ventilation pieces and put them together into an integrated machine, and it's made it much safer than it used to be. I see this vision of some similar opportunity on the medication side, some sort of integrated workstation. I don't know exactly how it's going to work. I'm hoping a lot of smart people can think and maybe figure out how to do this. But I think we have an opportunity to really lead the way rather than borrowing barcodes and things from other parts of the hospital to create a unique solution that works for us and that can really be an example to the rest of healthcare. So as you go back to your institutions, I just want you to think about taking pieces away, automating. What can you do to simplify your process, simplify your workflow? How can we eliminate steps in this whole process? You'll notice there's a bunch of Rodin sculptures. I studied art in college, so I like art analogies. And somebody once asked him, how do you make these beautiful sculptures? And he said, well, I pick a piece of marble and I just chip away all the parts I don't need. And that's really how I think about our medication process. How can I chip away the pieces I don't need? How can I make it simpler and more reliable and make it safer for our patients? Thank you.